Questions from the audience? I thought you put your hand up, Norm. You look like you're going to ask a question. You've held the microphone all day. You haven't asked one question. What's the matter with you? Yes, up here. Third row, fourth row.
I have a question for Dr. Stein. Our colleague from Texas had asked about the pressures and ventilating the pediatric neonatal patient about that, and I was wondering if you could address that a little bit with the need and want for higher pressures.
One of the things that we ran into early on was to protect our preemies' lungs, we're very, very cognizant of the amount of pressure that we're giving on the ventilator. And when we started with Nava, we would set our pressure limits at 22, 25, because we would hate to see our 500 grammers take big breaths. So we, being very smart neonatologists, knew exactly where to set our pressure limit. And all these babies would fail Nava because there's a problem with Nava, until we figured out that this was a problem with the neonatologists, and that preemies do physiologic breathing, the same as us. The sigh breaths we heard about, our preemies do the same thing. And little by little, we got comfortable raising the pressure limit. And now with Nava, and especially with Nava, personally, I start with a pressure limit of 40. And if the baby's not hitting it, I'll drop it down to 35, maybe down to 30, but hardly ever lower than 30, because remember, the ventilator will pop off at 5 below whatever you set it at. If you don't set it high enough, the baby can't recruit, and especially with these tiny little chests with very little muscle, they will develop progressive atelectasis. So one of the keys with at least neonatal ventilation, and I would defer to the adults to say, do you guys see the same thing here, is you need to allow the patients to recruit when they want to recruit. They know what they're doing, or they appear to know what they're doing. I've heard concerns addressed in, internet forums and some articles that I've read where they've talked about, wouldn't babies over-distend? Wouldn't they lung explode? Wouldn't bad things happen? And theoretically, I can see the question coming up. But between Akron Children's and ourselves, we have a combined experience. We must be over 700 patients between the two hospitals, and we've yet to have a lung explosion.
That's what you call noisy ventilation?
Can I have a question for Dr. Pratt?
Yeah.
Can I have a question? Yeah. I was wondering, as clinicians, when we have a patient on non-invasive ventilation, patient with COPD, and having, after 2 hours, say, high CO2 level, what we tend to do is increase the level of support. But looking at your data and interpreting them to the adult situation, might it be a good idea to reduce the level of support and hoping that you have more open probability of the upper airways? I think, is that a reasonable strategy to try?
Yes, but I don't have any clinical results.
Okay.
So I cannot go
But it
further.
makes sense.
Yes.
Isn't it? Yes.
One of the questions, the microphone there, one of the questions, until that microphone gets there, one of the questions that we've talked about is how to set the Nava level. And this came up in a few different talks, but we never really nailed it. So I wonder who wants to address that question? Leo or Jennifer? Well, how do you set the Nava?
I can make a start. As I said, we started out with doing the titration curves that has been published by Jennifer and Krister, and I think that's a good physiological rationale. But today it's so hard to do it in clinical practice. We tried for some time, for a couple of months, but it's not really feasible to do it. So I think while there's no evidence, it's very reasonable just to do it like you would do with pressure support. Titrate, for those patients who are awake, titrate to a comfort level. Make sure the patients are comfortable, and then try twice a day to reduce your level of support and see if they're still comfortable. I know it's not very scientific, but it's the same way we do it with pressure support, and that works for 15 years. So
I think it's very practical. What we do usually is that, since we start usually from pressure support, we start with this same pressure that
the overlay window.
Yeah. And it works most of the time.
Krister?
I just want to put in one point here. Looking at all the trials that have been done today with Nava, there's quite a few of them, and it consistently shows that whatever you set your pressure support, which everyone is already very familiar with, or whatever other modes has been tested, is that you find that the pressure with Nava is always lower, even though there has been at least 4 or 5 different strategies used to set the Nava level. It's not the physician who sets the Nava level, it's the customer, it's the patient. You can turn that knob to whatever. Once you get up on that plateau, you stay there. I mean, it doesn't matter how much you turn, the pressure doesn't turn. You just regulate the respiratory drive. You want a low drive, you get the low drive. You want a high drive, you have a high drive.
Question?
Hi,
Oh,
Carla
sorry, did you
from.
wanna-
Oh,
Jennifer, do you want to address that?
I was just going to mention a paper by Hadrien Rosé from France, and he did an interesting approach to titrating the Nava level. And because everybody's doing spontaneous breathing trials daily, what he did was he did a spontaneous breathing trial, and he looked at the highest EDI value he found during that trial, and he just took 60% of that value and adjusted the Nava level when he put the ones who failed, put them back on Nava, and adjusted the Nava level to target 60% of the maximum value that he got. He claimed this is a value that allows adequate activity and doesn't cause respiratory muscle fatigue. We don't know that, but the patients were 3 days ventilated at this level, and he repeated it daily. So that's another option, is to target an EDI value.
It has a strong physiological rationale. This,
The 60%. Yeah.
because it avoids fatigue.
Yeah, exactly.
Should.
Hi, Carla from Clinical Specialist for McKay, and thank you everybody for your presentations. Even for those of us that work day in and day out for the company, the knowledge has been amazing. My question is also related to pressure support, and what I find in the adult ICUs, and I can't speak for Europe, but in the U.S., setting pressure support tends to be a very cookie cutter. Either you use 5 or you use 8 or you use 12. There doesn't seem to be kind of a logical rationale for where they set this level. And this has been something I've been clinically seeing, and I'm wondering if any of you have also seen this, that elderly patients tend to be very sensitive to the pressure support levels. I'll go in and I'll find, patients on 10 of pressure support have very little EDI activity. I get them down to levels of 4 centimeters of pressure support, and their EDI activity comes back quite strong and very good signal. And maybe it's just that there are more elderly people on the ventilator, but I don't tend to see it in the younger patients as much as I do in the elderly. Could that be something physiologic with the pressure with an elderly patient?
You want to go through? I guess we want to ask Howard that question, okay? Elderly for Howard is like 1 week old. Antonio.
Well, I don't have an answer for the young versus elderly, but we have many ways to estimate what the patient is doing during pressure support beside EDI. We have the PO1, which can be measured by pushing a button. We have the PMI, that is the difference between plateau pressure, the inspiratory pressure, and plateau pressure if you push an end inspiratory pose. It will tell you how much the patient is working. And we found that quite useful in setting pressure support, because pressure support is an assisted breath. And so the point is, we should know how much we want the patient to work. And we can just estimate that, because measuring it is very difficult. Can be done, but cannot be done routinely every day, I guess.
I guess maybe the question more is that at least in the respiratory care community, 10 centimeters of pressure support does not seem like a significant amount of support to most clinicians at the bedside. Yet we'll drop the catheter and we'll realize that we basically turned the patient off with that value, which is deemed not very much. And I'm like I said, I'm just a clinician at the bedside looking at over many patients and just wondering, have we evaluated really what some appropriate levels of pressure support are in comparison to the EDI signals?
Great. Question over here? Norm?
Hi, I'm Lisa Laban, Connecticut Children's Medical Center. I have a question for Dr. Stein. On the patients that were extubated to NIV Nava, where did their pHs and CO2s remain while they were on NIV Nava? Or where did you allow them to be?
For our babies to remain extubated, they have to maintain a pH above 7.2325 and a CO2 less than about 65 with minimal work of breathing. They also have to keep their FiO2 below 50%. So we would consider an extubation failure if they exceeded any of those parameters. So all those babies that were successfully extubated and remained so met those and continued to meet that. Initially, when we started out on our Nava experience, every time we went to Nava, we checked a blood gas 1 hour after going to Nava, and then continued our usual Q4 hours, Q6 hours, depending on how small and early the baby was. We don't do that anymore. Once we switch to Nava, we usually go to every 12-hour gases, and within a day or two, we go to every 24-hour gases. Because 99% of the time, if the baby looks comfortable, the blood gases are good. If the blood gases are going to be bad, the baby looks bad. His work of breathing, FiO2's up, and you can really see it. So this has actually helped us. What we're saving on blood gases, we're spending on catheters. So it's been good.
Do they go into backup ventilation often, or are they still going
Backup ventilation is something we really haven't talked about here because you adults are so lucky. Your patients breathe. Neonates have apnea of prematurity, and it is very, very common that our babies become apneic. And apnea is defined in the literature as no breathing for 20 seconds. And that's where we started out. We set our apnea time at 20 seconds, and that means no respiratory support at all for 20 seconds, and then the baby would get a support breath. And those babies fell apart. So, of course, Nava wasn't working until we got smarter with this and realized that even on Nava, these babies deserve a minimal rate, and that the apnea time is what minimal rate is. So if you've got an apnea time of 20 seconds, that's a minimal rate of 3 breaths a minute. That's not your backup rate. That's the minimal rate the baby can get. So we have now managed to work with the company to allow us to set the apnea time all the way down to 2 seconds, which gives a minimal rate of 30 breaths per minute. Therefore, even if babies decide to become apneic constantly, if they go more than 2 seconds without taking a spontaneous breath, the ventilator kicks in with a ventilator breath for those tiniest babies, and that seems to keep them clinically stable. So with that in mind, how much time are they actually spending in backup? Well, the new trends that have just come out in January this year allows you to track per minute what % time you're in backup and how many backups per minute you're going into. And we find that babies are not going into backup more than 2 or 3 times a minute, sometimes 4 times a minute, which sounds like a lot. But then when you look up per minute, in 60 seconds, how much time are they in backup? They're in backup 10% of the time, maybe 12% of the time. On occasion, they will be apneic for 10 minutes, and in those 10 minutes, they are in backup 100% of the time. But it's very, very unusual that we see that. They go in and out of backup constantly. So apnea time has now actually, for us, is no longer an alarm setting, and I don't think it should be on the alarm screen. I think that apnea time is a ventilator setting, and that we should be writing for it when we write orders, because the shorter the ventilator time, the more backup ventilation this baby's going to get. It's not an alarm. It's actually a functionality of the ventilator. So that's one of our weaning parameters. If the baby's doing well with an apnea time of 2 seconds, we extend it to 4, 6, 8, 10. And then at some magic number, we decide the baby can actually sustain ventilation and we pull the tube. Or we stop Nava, depending on where we are. So apnea, which was an issue, it's just not an issue anymore. So we like that. The other thing is that every time they went into backup, the machine would call you and say, hey, I just went into backup. So, I went through a period where I was the most hated guy in the unit for all these alarms. That has been fixed. It now runs silently. It just goes back and forth and back and forth. In the neonatal mode, you have an ability to turn off this backup alert. Now, it's on the alarm screen, so when our lawyers heard that we were telling everyone, turn off the alarm, think about it. If your patient's having apnea, turn the apnea alarm off. So they came running down there to tell me I cannot do that. Until I explained to them it's not an apnea alarm, it's a backup alert button, which means that if your patient's having apnea, he will be going into backup. You don't need to be alerted. It's physiologic. Turn it off. If your patient's like all these guys who should not be having apnea, you do want to know when they go into backup. Leave that activated so it'll tell you when the patient becomes apneic and goes into backup.
Thank you. Question at the back?
In the back.
Norm?
Rollerblades. Who's got it? Santa Fe.
Hi. One of the populations that I dread putting on the ventilator are people with severe pulmonary hypertension. And I was wondering if you felt that there was any advantage to using Nava from the onset in patients who we ventilate with severe pulmonary hypertension in terms of their hemodynamics.
Who wants to address that? Antonio, you want to take that?
Okay, I'll jump in. I don't do adults, but boy, I have a patient population that has pulmonary hypertension. Our meconium aspirations, group E strep sepsis, these babies all have very high pressures in utero, and after birth, they are supposed to drop their pulmonary pressures. And if they have any of these insults to their lung, they don't. And they go into severe pulmonary hypertension, suprasystemic pressures, shunting right to left through their foramen and their ductuses, and they crash on us. We find that step number one, we put them on Nava. That reverses 50 to 70% of them instantly. They take over and they get better. Step number two, we start nitric oxide before we intubate them. So they are NIV Nava, start nitric oxide non-invasively, and that reverses about 80% of them. The remaining 20%, 15% of those go on to intubated, nitric oxide and all the other things we do, and that last few percent end up failing everything and ending up going to ECMO. But NIV Nava has changed the outcome. Now we jump to that right away. So from a neonatal pulmonary hypertensive standpoint, they fix their own hemodynamics very quickly. We see that both by echocardiographic evidence with dropped pulmonary pressures, as well as blood gas evidence by resolution of their metabolic acidosis. That improves very rapidly. And the saturation difference, which you don't have in adults because you don't have these big shunts, saturation difference resolved very rapidly as well.
One of the things we talked about this morning was what are the best studies to do. So I said we come back to that. What are the best patients? Thank you very much. Jean-Paul has to leave. What are the best patients? Who do you think would be the best patients to put on? And what studies do you think should be done to look at this issue of outcomes? Be interested. There are neonatal studies that can be done. There are certainly adult studies, non-invasive studies. Yeah, there's a microphone.
So, Howard, maybe you can help me a little bit here, and maybe we can design it together. But I think that the whole thing about neurodevelopmental outcome is a hot topic in these premature babies. So I would like to start off by looking, first of all, at how babies are sleeping on Nava compared, because we haven't talked about sleep very much. But in the adults, we know that sleep quality is improved with Nava, and I would like to study that in premature babies with the whole EEG, get up, everything. And then, depending on those results, I think that might be able to tell us what we can expect from 5 years from now from that. So I think that's... Does anybody else have a comment about that?
What do people in the audience think?
Yes, sleep is good.
I see a lot of heads nodding. Anybody else? What about non-invasive ventilation? Leo?
Yeah, I think that would be the easiest trial to go for clinical relevant outcomes, to look at non-invasive ventilation. I showed some examples, and my clinical feeling says that with non-invasive Nava, you're going to prevent intubations. It's going to be the easiest study to perform. I think doing really outcome studies on invasive Nava, that's going to be really hard. We all know the large clinical trials in ICU patients, the outcomes, it's so difficult. Our populations are so heterogeneous. We know about the PEEP trials. We have thousands and thousands of patients. We still don't know the answer. this is going to be really difficult to do trials in invasive Nava with clinical relevant endpoints. But it's going to be much easier with non-invasive, I guess.
I wouldn't say in people we don't know. It's a definite maybe.
It's a definite maybe. Exactly. But because it's such a heterogeneous population. I mean,
Very difficult.
Sue Pilbeam, consultant with McKay. Actually, I think something that might not be too difficult that would make administrators happy in terms of money is if you could do one on reduction of sedation with Nava. If you just demonstrate, particularly if you got a patient who's really fighting the ventilator, as in wants to pull the tubes out and everything like that, and get that population, and then try Nava and see if you can reduce the level of sedation. Propofol is very expensive. It can run $800 a day. And if you did nothing but that and that was your outcome, I think that connecting the dots with the research that's already been done might be helpful and not as difficult.
It's interesting. I just saw a letter to the, was it a letter to the editor or a small article in a case report in intensive care medicine about a patient who had a drug history, ended up in the ICU, was in the ICU for 6 months, and they calculated the sedation costs were about 160,000 euros. It was mind-boggling. It had nothing to do with Nava or ventilation, but it struck me like, wow, that was incredible. So
I think, however, that we should define what we want to compare with, because it would be easy to compare the advantages of Nava against controlled mechanical ventilation or even assist control, which is an assisted breathing modality very difficult to handle properly, assist control. But to compare Nava and pressure support will require a lot of planning and a lot of selection of patients. And the final argument there will be, why should I have 2 ventilators in the unit when I can have just one? And so just use Nava instead of pressure support. I might be biased, but I think besides non-invasive ventilation, which is probably the easiest, the most productive study to do, I, in a way, doubt that we can measure a decrease in sedation between pressure support and Nava, except in very selected categories of patients. I think the other category, me being biased, is the weaning of severe ARDS patients. If we can start weaning 3 days in advance, we gain a lot of benefits, even with just 3 days.
Yeah. As you say, Antonio, I think what we're doing here and what we haven't discussed much today is that Antonio has talked about it and so has Howard, that we are going into we are into a situation here where we are breaking new grounds. We are actually going into patients that could not be touched before. For non-invasive ventilation, technically, our experience from animals, you can ventilate anything in any condition. It's like there's no limit to it. The only limit is you might have to control CO2 in certain situations, and then you have to get the drive down so that you don't get those tidal volumes that would be difficult. And I think if we take a trial versus pressure support, yes, the trial would work if you start the weaning earlier, as Antonio said. If you go on, do the trials, when you start Nava is when pressure support don't work. Then you can go in and say that Nava is clearly better, and you would save days. But how do you include the patients when you can't use the other mode? When you put both on the same thing, when you're so good that you can use pressure support successfully, why do we need Nava? If pressure support works, it works, correct? But when it doesn't work, then Nava works. And Nava works better than assist control when it works in those patients. So we are in some kind of different layers here. So it's very hard to design these trials from that point of view. Therefore, that's what I'm saying. We have to go in from the day one on the patient and decide upon the strategy from day one to do these trials, because everything has to change, because sedation will change with it.
Any questions from the audience? We're at 5 o'clock, and I said I'd try to finish up by 5 o'clock. So let me start.
What's in the bar?
Yeah, exactly. Let me start by thanking all the speakers. I think some excellent talks, excellent discussion.